Thanks for having me back, and I guess I'm going to start first by asking, has everybody figured out ramp lesions? Everybody figured out root lesions? You think you could get just a little bit more? Okay, so well, I think that the talks from both Jacques and Mohammed were phenomenal, and I think that they give you a great understanding of these different things. So I'm going to kind of walk you through these issues that we've just faced. My first talk was about degenerative meniscus tears. I was kind of talking you out of doing meniscus arthroscopy, except for indications. Here I'm going to tell you this is why we should be doing arthroscopy. So basic science validates improved contact forces and function at time zero for virtually all of those repairs Jacques was telling you about. Newer tools and techniques allow the repair of dysfunctional tears like the root, radial, and horizontal tears, and help secure instability tears like the root, ramp, and extruded types of meniscus. Certainly, reducing the risk of expedited progression of arthritis over time is going to be critically important. The other thing we need to know is that it improves population health because 35% of the tears are likely repairable, but we're really only targeting about 15% of them. In fact, I think when we learned how to do all inside meniscus repairs, the total number of meniscus repairs we were doing jumped tremendously, which helped the global population because we saved more meniscus. So which menisci are repairable? From 1990 to 2020, it was probably the peripheral third red zone vertical with an ACL. That was our classic indications. But clearly now we need to be looking at all of these things, the root, the ramp, radial, and horizontal cleavage tears. You're going to see several videos that I'm going to tell you that I'm sharing with my good friend Rob LaPrade, who helped share some of these. But the reason that we're very close, but I sent one of my residents to work with Rob in 2013, John Watson, because I had an idea. And my concern was that when you did ACL reconstructions, I was pretty goddamn sure that we were damaging the meniscus, which then led to anterior horn root tears that led to arthritis. And so we sent him to the lab with Rob, and with that, we ultimately find that that's actually true. So there are certain things that you have to pay attention to. There's iatrogenic risk of the roots when you do ACL tunnels, when you do tibial routings, when you do PCL tunnels. And so ultimately, you have to be aware of that iatrogenic potential injury, and then when it comes time to fix these things, that we do the anatomic types of repairs. So what we know is that anterior lateral meniscus root has about 40% overlap with the ACL, which means if you're doing tibial tunnels for your ACL, you're probably getting some of that root. Posterior lateral meniscus root is 1.5 millimeters posterior and 4.2 millimeters from the lateral tibial eminence. So again, it's close to if you're doing a PCL tunnel. So you have to pay attention to those things when you're doing when you're looking at those surgeries and see if you're causing damage. Medial meniscus posterior root distance is about 0.7 millimeters from the lateral medial eminence and about 9.6 millimeters posterior to it. So you have to pay attention to all of these anatomies, both to understand the potential injuries of risk by iatrogenically, but also when you want to think about repairing them. You've seen this picture. It's from LaPrade's work in terms of making these diagnoses, in terms of looking for root tears. And basically, you're looking for something that's within about 1 centimeter. Why? Because this type 2 ones are the most common, and they're the easiest probably to potentially repair. Not that you can't repair type 3s, or certainly avulsion injuries, certainly easily repaired, but those are the ones you're going to most commonly see. And you want to look for it. This has been emphasized by Mohammed, is that if you don't look for it, you're not going to see it. Here you can see that posterior root hiding underneath the ligament of Humphrey. It looks fine to me right there, right until the time you probe it, lift up, and you can see how unattached it is. These clearly cause additional pathologies within the knee, including a 3+ extra Lockman. If you look for that, you probably have an associated meniscus pathology or certainly other ligamentous injury. LaPrade showed us a long time ago, if you miss those diagnoses, if you miss an associated collateral ligament, if you miss a posterior lateral corner, if you miss a root tear, your ACL outcomes are going to drop. Failure to restore to an anatomic position is also a problem, which means if you actually don't put your root repair back to where it was supposed to be anatomically, you don't resume the normal contact pressures. With that, you're going to have a higher risk of arthritis and failure. Root tears that are chronic commonly sublux posterior medially. And you saw that that one case where they did the release peripherally to bring the root anchor back to its anatomic position. You have to pay attention to that, both with the ramp and the root lesions, because if you repair them non-anatomically, you're going to have a higher risk of failure. And if you look at the pictures, here you see the anatomic repair, which actually approaches an intact meniscus. However, a non-anatomic repair, you can see that you have increased contact pressures. So here you can see another thing that I think I personally said, hey, I'm going to do this simply. When I do an ACL, if I see that root tear because it's near the ligament of Humphrey, I'm just going to tag the root and pull it down my tibial, my ACL tunnel. Not true. It's about a centimeter difference in terms of distance, and therefore you're creating a non-anatomic position, and if you do that, it's going to fail. Certainly we have many more tools now to work with. You saw some of the curved suture passing devices. There's these types of devices, all that help make it easier. They actually now have curved devices from one company that help get you a little farther down the route to try to get the repairs. You're also shown how arthroscopic pie crusting or doing trephination of the medial meniscus can help. Clearly, if you actually try to work on this and you're in a particularly tight meniscus or a tight joint, you really can't get everywhere you need to do to try to repair these things. However, you do a little bit of a soft tissue release, generally about 15 to 30 degrees of flexion of the knee, create some valgus, work on the posterior aspect of that medial collateral ligament. Next thing you know, you get some increased gapping and you're able to work back there. Good news is that generally resolves. That has not been shown to be a long-term issue in terms of instability. Here you can see just the final preparation after two large sutures were passed through a root tear. And we'll just kind of move forward. So examining the efficacy of the medial meniscus root, do they actually work? Let's look at some of the outcomes. This was an outcome study in 2023, 13 biomechanical, 23 clinical studies. What did it find? This is for the medial meniscus root. All outcomes in terms of IKDC, HSS, Lysholm, Tegner, and Coos, all patient-reported outcomes improved. So you got to be doing these. What interestingly was, it also showed that it did not really necessarily improve meniscus extrusion, which means we're probably not getting this anatomically correct quite yet. If you're doing these and you leave extrusion, it's probably not right. So, on the other hand, if you do this actual peripheral release and you do some type of a peripheral anchor, so you're actually stabilizing the peripheral root back to its corner on the tibial plateau, and then doing your root repair, then you have a much better chance of preventing extrusion. You're going to have a better outcome. So how about radial tears? Does radial tear equal an irreparable tear? Well, historically, that's what I learned, and that's what I was teaching my residents. But the answer is absolutely not. The question is which repairs are going to work best? So if you actually, this is a study done by Kevin Shea and others out in Stanford, and they did kind of a cross-hatch type of a repair. They did kind of horizontal parallel repairs. And here you can see what the pull-out strength is of each of those. And you can see absolutely the rebar or hashtag technique has significantly better pull-out. And so if you're going to be doing these radial repairs, you really have to be doing that type of a procedure. Current standard, repair radial tears if possible, especially in younger patients. Use that hashtag technique because the pull-out strength is better. If you actually have a peripheral, unstable, inferior meniscotibial ligament, then you actually may have to place an anchor peripherally to lock it down before you actually do the hashtag repair. Here you can see a radial tear preoperatively, intraoperatively with a hashtag, and this is a second look arthroscopy at 6 months later where it actually showed a pretty nice repair. I would have bet against that 10 years ago. Repair of the radial meniscus, what are their outcomes? 2021, 12 studies, Lysholm scores all appeared, increased 47 to 68, up to 86 to 94. Tegner activity scales improved from 2.5 to 3 up to 4.7 to 6.7. Healing rate for a radial tear at second look arthroscopy, about 62% had complete repair healing and 30% had partial healing. So 92% of the time you're going to get something back in terms of function. We talked about ramp lesions. It happens about 15 to 25% of ACL injuries. and it's about missed about 50% of the time on the preoperative MRIs. What does that mean? You have to look for it. I think you've got that message already from the last two speakers. You have to put your scope posteriorly. You have to do that, look posteriorly, probe posteriorly, look to see if it's actually present. Once you've identified it, what did we just say? If you fail to identify a posterior lateral corner injury, a lateral collateral ligament, medial collateral ligament, or a root tear, or a ramp lesion, your ACLs are all going to fail or have a higher failure rate. So you have to look for these to optimize your failure rate. How about management of ramp lesions? What are their outcomes? 7 studies, about 509 patients. Again, what do we see? Patient reported outcomes significantly improved with these repairs, both the lysosome and IKDC. Second look arthroscopy also showed a very high healing rate, only about 8% failure. How about horizontal cleavage tears, which is gets back to my first talk in terms of degenerative meniscus pathology. Well, if you actually see these, you shouldn't be actually removing them. If you actually do a debridement, you dysfunction that meniscus. If you remove a single leaflet, which is what I used to do, take the top one, leave the best looking one that you have, take the top or bottom one. Bad idea. Single leaflet decreases your contact area by 82%, so increases your contact pressures. So actually the best thing to do is to try to repair them. So basically sequentially, you're going to put an anchor above and below, tie them down. You probably need multiple anchors to try to get it. Ideally, you could actually put some PRP or try to create some bleeding to help that heal. What are the outcomes here of horizontal meniscus pathology? This was just back in 2014, but nine studies, 98 patients, 77% success rates. If you looked at the outcomes in horizontal cleavage tears versus vertical tears, at 3-year follow-ups, they actually had no difference. So they were just as successful as repairing the classic vertical peripheral meniscus tear. So we should be fixing these too. So in conclusion, preserve the joint, expand your indications if you haven't already, look for those atypical pathologies, and save the meniscus, including complex meniscus, root, ramp, radial, and horizontal tears. So, and remember from my last little talk, just some opportunities through ANA. ANA.org is just a possibility for you. I gotta see, I think that ESCA course was the end of November, so I think you could still do both this course and the ESCA course, so there's no conflict, and all the different other courses available to you in Chicago at the Orthopedic Learning Center. So thanks for your attention.